Okay, I think we will go ahead and get started, and I'll start to walk through some of our initial introductory materials and as hopefully more people filter in as we start to get going. So welcome to this session of the 2022 Culture of Data Conference. I'm excited to have you all here. My name is Rebecca Reese. I use she, her pronouns, and I will be moderating today's session. We also have Kayla Gilbert on. She is helpfully also tagged as tech host. So if you have questions, she will be around throughout the session to assist with any tech difficulties that come up. So please feel free to message her if you have any questions. You are all muted now upon coming into the room, but if you have questions during the Q&A session, I would invite you to come off mute. If you feel more comfortable or if you have questions throughout the presentation, please feel free to put those or any comments in the chat. We will be monitoring that and bringing them up during the Q&A session as well. If you are comfortable doing so, I would invite you to please add your pronouns to your Zoom name, and you can do that if you hover over your image. There are 3 dots that pop up, and if you click on those 3 dots, there's an option at the bottom to rename yourself over Zoom. So if you're comfortable, I would invite you to do so. We have 2 wonderful presentations lined up today, which I'm really excited about. So how today will work is we'll have 2 20-minute presentations, a 10-minute Q&A for each, and we'll have a 5-minute break in between for people to stretch, take a break, step away from their screen for a moment. And as you all read, which I'm sure is what brought you to this session, the theme of today's session is maternal and child health in the Mountain West. And so our first presentation is the Health First Colorado Maternity Report, and that will be presented by Tamara, Keeney, and Susanna Snyder. And so I will hand it off to both of you.
Great. Good morning, everyone. My name is Tamara Keeney. I am the Research and Analysis Manager at Colorado Medicaid, also known as HCPF, Healthcare Policy and Financing. And I'm joined today by Susanna Snyder, who is our Maternal Child Health Manager. So as was just mentioned, we're going to be talking through the Health First Colorado Maternity Report that we worked on last year. So just a quick agenda of what we'll be going over today. First, I'm going to be talking about the quantitative approach that we took for this report. So I'll talk through some of our report goals and objectives, talk through the report methods, and then show you some data highlights. And then I'll hand it over to Susanna, who will talk about our Maternity Advisory Committee. She'll talk about storytelling and data in this work, and then some of the program expansions from the department. So to start with our quantitative approach, we really began this project because we wanted to create a tool that would provide us with the data needed to understand trends in maternal health and identify targeted interventions to improve maternal health outcomes and reduce health disparities. And we were able to create this tool, which takes the form of a Tableau dashboard, through a partnership that we have with the Department of Public Health and Environment, which allows us to link a birthing parent's Medicaid ID with their infant's birth certificate. So it's a unique source of data that gives us information, again, tying together some of the health behaviors and prenatal care data with the infant's birth outcome. So it's a pretty cool data source, and we are excited to use that to create this report. So our report objectives were to use that linked data. So in this case, in the calendar year 2020, we were able to analyze 84% of births that could be linked between the birthing parent's Medicaid ID and the newborn's birth certificate to highlight areas of opportunity and improvement. And we really encourage partners, including all of you on this call, to use the report to inform strategies and targeted interventions in the maternity space. And then one last note on methods. You'll hear in this talk and in the report, we use the language of birthing parents or members who have given birth. And we chose to use this gender inclusive language because we wanted to acknowledge the experiences of all of our Health First members who are giving birth or are pregnant. So with that, I think this graphic probably won't come as a surprise to those of you on this call, but just to give you an idea of the scope of Health First Colorado's impact on this population in our state, Medicaid covers over 40% of all Colorado births. So this map is showing you by county what percent of births in that county were covered by Medicaid. So it ranges from a low of 14% in Douglas County in the lighter shades of blue, up to a high of 78% of births in Bent County on the Eastern Plains. So in 16 counties in our state, which is a quarter of all counties, there was a Medicaid coverage rate for births of over 60% or higher. And you can see in this map, again, in the darker shades of blue, that those are mostly in Southern Colorado. So the report, which I'll put a link to in the chat when I'm done presenting, has a table at the back with each county and the percentage of births covered by Medicaid for use by legislators or other stakeholders. So I talked about this a little bit in the introduction, but wanted to get into the weeds a little bit of how we're able to do this matched ID data source. So the way it works is that HCPF sends CDPHE the Medicaid IDs of members who have given birth. And then CDPHE matches those IDs to the birth certificates of newborns, and they do that in a few ways. So first, they use the maternal Medicaid ID. They can look at the maternal or infant social security number, and they can also match on the maternal or infant date of birth. And so once they do that, they send us back the matches. And as I mentioned, in calendar year 2020, this was an 84% match rate. So about a little under 22,000 births. And we're continuing to look through that 16% that we're able to match. And so far, what we can tell, part of the reason for the gap is really just a timing thing. So there's a timing gap between when we receive claims for the pregnant person, when we send the file, and when those matches are made. And then the other piece of the gap are our members without documentation. And so we would not have a Medicaid ID prior to them giving birth. And so there's nothing to match on in those cases. And I will note that the report that's on our website is calendar year 2019 data, but I've updated it for this presentation to be calendar year 2020. So you're sort of the first people who are going to be seeing this new data that will release later this year. So the report has a huge emphasis on race ethnicity. And so I wanted to just show you what the race ethnicity breakdown looks like in our Health First pregnant Medicaid member population. So this pie chart is showing you, we can see right away that our Hispanic members make up about 43% of all births. And this data comes from the Medicaid application. So this would be using the information that our members would use to identify themselves when they sign up for Medicaid membership. The second largest group are white members. So that's about 1/3 of pregnant Medicaid members. And then you see some other groups here. So Black African American at 7.7%, Asian about 2%. And then you see this unknown other race at 13.4%, but I wanted to give you a little bit more insight into what that actually includes. So within that group, 5.2% are those who we just don't have any data on. Other, so those who actually marked that they were not one of these and that they were another race or ethnicity is about 6%. And then there's this other group of not provided at about 1.4%. So now let's get into some of the data. So our data set gives us information on health behaviors. So I wanted to highlight that here. And one of the health behaviors we cover in the report is smoking tobacco during pregnancy by race ethnicity. So about 1 in 10 members said they smoked tobacco during pregnancy, but you can see that there's really wide variation here when we look at different race ethnicity groups. So you see that white members were the most likely to report that they smoked tobacco during pregnancy at 17%, followed by American Indian Alaska Native at 14.3%. So you see that this non-Hispanic white number is about 3 times as high as the Hispanic number at 5.7%. And why does this matter? Why did we decide to focus on this? And it's because we know that smoking during pregnancy can have harmful impacts on the newborn. So here we wanted to show one of the advantages of this data set is, again, being able to tie the birthing parents' health behaviors in the prenatal period, and then what we see in terms of outcomes. And so we see that among members who smoked during pregnancy, 17.5% gave birth to a low birth weight baby, and that was compared to 9.8% among non-smokers. So we showed this data to our regional partners and were able to provide them with what their rates looked like by race, ethnicity, and their region, and really tried to spur new conversations about smoking cessation in their regions, particularly among white members. And to go a level deeper, what we saw was really rural white members who had these higher rates of smoking tobacco. Here's another example. So another section of the report covers different health conditions. So here we're showing chronic hypertension, again, by race, ethnicity. So we showed this because chronic hypertension has numerous health risks associated with pregnancy and delivery, such as preeclampsia and potential hemorrhaging. And our data shows a stark disparity in the diagnosis of chronic hypertension by race ethnicity, particularly for our Black members. So among birthing parents who self-identified as Black and gave birth in calendar year 2020, 12.6% had a diagnosis of chronic hypertension. So you see that that's about 50% higher than the rate for our white members, and it's double the rate of hypertension that we found with our Hispanic members. And again, why does this matter? We're able to use this data set to look at outcomes for the newborn as well. And so we see that among members who have a chronic hypertension diagnosis, 22.6% gave birth to a preterm newborn. And then among those who did not have that diagnosis, it's about half at 9.4%. So again, what we've been doing with this data is using it to talk with regional partners, to talk about the need for comprehensive prenatal care, particularly for our Black members, to talk about and treat hypertension during the prenatal period. So happy to go into any of that in the Q&A, but I'm going to turn it over to Susanna to talk about the qualitative work that's gone into this report.
Thank you, Tamara. So given what she just shared about these disparities, we know it's imperative that we not just get the narratives behind these numbers, but also move them to those narratives to sit next to these numbers. And we have an emerging ability to be able to do that and invite feedback on this nascent project. So next slide, Tamara. It was fall of 2020, the department was running a rule through our medical services board about an emerging project to bundle some services around maternity care. Our stakeholders were worried that we weren't centering the member experience in that project. And so they asked us for that particular project to invite some member feedback. And as we discussed this internally, we realized there was really a larger scope in which we needed new parent voices involved in policy. While we have a member experience advisory committee, it kind of pulls from each different population, but we decided that the work with this population was so important that it warranted its own member group. So we created, that's now codified in rule, a maternity advisory committee that leverages the lived experience of maternity care to inform policy, with this really critical component that it's composed primarily of Black, Indigenous, and people of color. Knowing what we know about the burden of maternal morbidity and mortality on our populations of color in our state and nationally. We created an application with stakeholder feedback. We received over 100 applications, which was really impressive and a little overwhelming. We didn't expect to get that many, but it was great. We interviewed over 30 people and selected 16 individuals to move forward on the committee, and we started meeting in August of 2021. Next slide, Tamara. In those meetings, we were determining first how we wanted to engage. We decided that we would meet one time a month for 90 minutes with alternating times, which we're still trying to determine if that's the best way to do it. But just given the complexity of this population, one of the provisions was that members had to have had a child on Medicaid within the previous 5 years. So we're dealing with new parents with young children. We're dealing with different work schedules. Some people work days, some people work nights, depends on when people can get childcare. So we have a daytime meeting and a nighttime meeting. And so we generally have kind of like two cohorts of the meeting. And as such, we even actually invited some people who were like on our wait list into those meetings to create a little bit more of a cohort in each of those two groups. We do reimburse folks for their times, and we do reimburse for childcare, though it's a little bit challenging through the state system, which is something we're trying to work on. We do have, we are entirely remote right now, and even if we do move to an in-person option, we are going to retain a tele option because this did allow us to recruit folks from the Western Slope, from some of our more rural and frontier areas, trying to get more of that geographic scope. We're currently working on creating bios with pictures that we can put on our website and developing these priorities. So these are some of our emerging themes. I think one of the really shouldn't have been surprising, but was something that we felt like we needed to respond to very quickly, was how important that this be a trauma-informed space. Many of these folks are still actively trying to treat behavioral health conditions resulting from perinatal mood and anxiety disorders, complicated by many reports of implicit and explicit racism that they've encountered within the healthcare system. So pretty quickly, we've tried to engage a licensed counselor who is now going to be attending those meetings and acting as both like a co-facilitator in creating that safe space, but also contracted to do one-on-one follow-ups with members, whether they're in acute crisis or helping them get connected to the resources that they need within their communities. And that's something that we're really excited about and think is really needed in this space. Another really strong emerging thread was around postpartum support and community. Obviously, the first two are kind of related, right? You know, if you're not receiving that postpartum support you need, you're more likely to suffer from perinatal mood and anxiety disorders. A lot of focus on special populations, people who had older pregnancies, younger pregnancies, people in school, tribal populations, trying to accommodate for the multiplicity of experiences while also moving forward the unique needs of the population. And then finally, that labor and delivery treatment. A lot has come up around informed consent, pain management, also things that we know from the literature are closely associated with race and ethnicity and differential treatment according to those things. And the really strong trend from this was we want to share our stories. We want our stories to be heard. We want people to know what we experienced. So we've ended up with this really nice synergy between, you know, working through the maternity report for that first time, getting those numbers together, really sharing them, and knowing that we wanted to bring more of these stories to the table and having this place where people are saying, and we want to share our stories. This will be a pretty new area of work for the department. While we do have a lot of people with research background, including myself, it will be a little bit of an uncomfortable space for a state department to lean into letting our members drive the story. And one of the things we've heard really strongly from the members is they need to be our stories. We don't want you to take our stories to tell the story you want to tell. So there's going to be a lot of trust generation that's going to be really critical to that work. Next slide, Tamara. So these were the options we gave them. When we came to them and said, you know, first they were saying, we want to tell our stories. And we said, okay, well, there's a couple of different ways we can do this. First, we could create like a standalone, systematic, qualitative analysis of your stories where we'd, you know, create, you know, a standardized, semi-structured interview questions, do full thematic analysis, and publish this, you know, to sit alone, but maybe, you know, in concert with the quantitative report. The downside of that, it's going to take a while. We don't have a whole bunch of resources. We're scrapping together, trying to find funds and personnel who can invest in this process. But obviously, this would be the most robust option. Option two was to create accent narrative in the maternity report. So where we take the data that comes out of our second report and we bring it to the group and say, does this resonate with you? Does anybody have a story that could really amplify these kind of data points? And we shared that you wouldn't be driving the narrative as much. The numbers would really be driving and you would kind of follow in this scenario. But we could probably do it pretty quickly. So if you want your stories out there and you want them out there quickly, this is probably the most expeditious route. And then finally, there was this kind of like in-between option as potentially like an appendix to the quantitative report where we, you know, kind of just like plop the stories in without a lot of analysis for, you know, some extra reading for folks who are interested. And what they said pretty clearly was, we want 1 and 2, which is great, which means that, what we're hoping to have in the fall is something that, is the second iteration of what Tamara's presented here today, with some of those stories to accompany. And then within the next 18 months, really a standalone report that could either be published at the same time as the maternity report, or maybe on the 6-month basis. So you kind of have this rolling system. And we're still playing with how that might work. So we're really excited. Next slide. Because we do have these exciting initiatives coming up. And while we're always doing really cool work at the department, these are some really big programs that are really going to change how we deliver care in the state. And we need feedback on them. We need to make sure we're doing them right. We need to make sure we're centering the member experience. So the first one of these is family planning for Coloradans without documentation. So while these individuals have been able to receive some family planning services on a sliding scale through Title X clinics, this would make them eligible for Medicaid benefits, which has a larger reach throughout the state. We have more providers with 12-month supply of those services. The second one is family planning for Coloradans with an expanded income threshold. So this currently our income threshold is approximately 135% of the federal poverty line, and this would move that up to 260%. So now there will be a limited benefit category for people who may be eligible for the exchange, but that's another conversation, have trouble accessing services through the exchange, can now get free family planning and family planning related services. The third one is postpartum coverage. Previously, folks, about 3,000 to 4,000 individuals per year might lose Medicaid services at 60 days postpartum due to income thresholds that change between being pregnant and being a non-pregnant individual. Now they will be locked in for 365 days, which is especially important for what we know about those perinatal mood and anxiety disorders and any other number of things. And then finally, we are working on a maternal opioid misuse grant, which is a federal grant that will integrate obstetric and opioid use disorder services. We have 3 subgrantees across the state, and this is a population that's historically been very hard to treat. There's been a lot of reluctance on the part of providers, and these are the kind of things that we really need to bring these qualitative experiences to informing, as well as having these kind of standalone quantitative reports. So with that, Tamara, do you have anything to close us out? I know I'm getting close to time.
No, I don't think so. I think I'll stop sharing so we can see everybody, and then we're happy to take questions.
Thank you both so much. This is what I'm finding I love more and more about my work is meshing or melding together the quantitative and the qualitative, and really bringing that those stories and that flesh and the meat to the numbers, to the bar graphs that I think we're all used to seeing in our field, and valuing it the same way as we do the quantitative data. We had one question come in. Can you talk a little more about the criteria for selection in the Maternal Advisory Committee?
That's a great question. So the criteria for application was pretty low. It was had a child on Medicaid within the previous 5 years. When it came to the more subjective experience of interviewing folks, we looked at ability to attend meetings was even to make it to interview. Believe it or not, even just that precluded some people. And we had a rubric by which we evaluated folks based on variety of experience. We did have to wait more for Black, Indigenous, people of color to get that majority there. And then ability to commit to the work. So it was a pretty low threshold to get us to those 32 participants made it to interview. Then for the interview process, we divided up the groups into, I'm trying to remember exactly how many cohorts we had, but we had 3 interviewees attend each of those interviews and then review those interview notes and try to make it so that each cohort took about, I think it ended up being 3 folks from their set of 8 interviews to final panel. But say, for instance, there was flexibility there because the group I was in, we had a lot of really strong candidates. And so we actually advocated to have more of them put in. And then, as I mentioned, we had that kind of like wait list of, okay, if somebody has to drop out, here are some folks who are also really strong. And we've already pulled 3 people off of that list to participate in the larger group.
Awesome, thank you. How did Title V funding contribute to the project, or did it?
Yeah, so as Medicaid, our funding comes from Title 19 of the Social Security Act. So all of our funding for this comes from our Medicaid funding, which is both state and federal dollars.
We had another question just come in. How do you plan to address the fear birthers might have around having their child taken away with the obstetric and opioid misuse disorder program? And do you expect significant barriers to enrollment?
Yeah, so there's a lot of really good work going on in that in the state. And so in an effort not to duplicate efforts, our program coordinator for this project, Anushka Miliar, whose information I can drop in the chat, is working closely with the Substance Exposed Newborn Policy Committee and Illuminate Colorado and the Chosen Collaborative to leverage some work they've already been doing about creating safe spaces around that, which is really bidirectional. It's both like informed work with the patient as well as educating providers on what's appropriate around testing, around communicating around testing, around sharing, you know, what the thresholds for engagement with child services might be. It's always going to be a tough space because there's never going to be any guarantee there. You can't say this isn't going to happen, but trying to use some of that language around, you know, actively seeking prenatal care and treatment is not, will work for you in those cases, not against you.
Thank you. One more question. Can you speak to the overall tobacco use and hypertension rates by race, ethnicity, I think, compared to this potentially pregnant or perinatal population? How do the overall tobacco and hypertension rates compare?
Sure, I can speak a little bit. So our research really focused on the within Medicaid population, but we did look just broadly to see, and I think we compared to Colorado and the rest of the United States. I remember when we looked at the hypertension rates, we did see a higher rate for Black birthing parents across the board, regardless of Medicaid versus non-Medicaid. But I think, again, I can't pull any numbers off the top of my head of what it was for tobacco use. I think we found that our members had a slightly higher rate of tobacco use, but the trend of white members having a higher rate of tobacco smoking during pregnancy compared to other race ethnicity groups was something that we saw outside of Medicaid as well. I don't remember the scale of the differences, but I do recall seeing that the overall trend was the same, that we did see non-Hispanic white members having higher rates of smoking.
There was another question that came in that I'm actually very interested in as well. Is there a standardized way to collect race and ethnicity data between the birthing parent from Medicaid data collection and the infant through vital statistics?
That's a really interesting question. I can speak to the Medicaid side. I don't know as much about the CDPHE birth certificate side of things. So if anyone on this call does have information on that, would love to hear it. This topic of collecting race ethnicity data is something we've been discussing a lot at the department. And so we've been really digging into our applications to look at the different ways that we collect race ethnicity data and looking into the literature to see what are the best practices. And it's something that we are actively working on within the department to look at the way that we ask race ethnicity, because we know that, number one, across all of our applications, there are slight differences. And we also know that the way that we currently ask race ethnicity as 2 separate questions isn't necessarily in line with the way the research points to the way we should ask that question, which is in a single question format. And so those are active discussions on the Medicaid side of things, but I truthfully just don't have enough knowledge to speak on the infant vital stats data collection side of things.
I know a very small amount actually that I I think there's a lot of issues and ingrained historic racism and discrimination with infants automatically taking the race or ethnicity of the mother. And I think I dove down a very long historical deep dive into that one day, like connections to slavery. And I know that there's now ongoing discussions about how to do that in a more appropriate way that takes into account the parental decision about what race or ethnicity that they want for their child, or that they would identify their child as. But I don't have the perfect answer for how those then are standardized across the two or connected. We only have 1 minute left for this, so if anyone has any more questions and would like to come off chat, I would invite you to do so. Thank you both for starting us off. That was such a wonderful presentation, and I'm really looking forward to seeing the next iteration with all of those narratives and stories, and then that long, lengthy standalone report at some point in the future as well.
Great, thanks for having us.
Thank you so much. So now we will take a brief 5-minute break for you all to get up, stretch your legs, step away from your screen if you need to, and we will reconvene at 10:51. I'll put that in the chat. Thank you, everyone. Okay, wonderful. Welcome back, everyone. We will move into our next presentation. I hope you had a quick chance just to stretch and step away from your screen. We're going to jump right in and get into it. So our next presentation is entitled How Data, Community, and Culture Combine to Support the Well-Being of Minority Women in Utah. And here with us today from Utah are Deepani, Jinadasa, and Naes, and they will be sharing their work with us today. So thank you both.
Thank you all so much for having us today. And welcome to our presentation. Today we'll be sharing about the Embrace project study. And as mentioned, my name is Bon, and I'm here today with my colleague Deepani, who is the Health Equity Epidemiologist at the Utah Department of Health Office of Health Disparities, and I am the Health Equity Program Specialist working on Embrace. And as mentioned, please hold all your questions until the end, until the Q&A session at the end. So during this presentation, we hope that you are able to see these three things throughout of our project objectives, and that is to prioritize a health equity approach when designing health and public health services and interventions, including the collection of data from community members, to use culturally responsive and tailored programming for racial and ethnic minority communities, and to review evaluation methods for measuring the impact of culturally responsive and tailored programming. And the Embrace Project study could not have been possible without the collaboration and partnerships between the Utah Department of Health Office of Health Disparities, sorry, are you guys able to see the project partners slide?
We're still on your intro slide.
Okay, let me see. Okay, how about now?
Yes, we're on the project partners.
Perfect. Sorry about that, everyone. All right, so the Embrace Project study could not have been possible without the collaboration and partnerships between the Utah Department of Health Office of Health Disparities and the Wellness Bus, who is pictured on the slide and is implementing the study, along with all of the community-based organizations who are listed on this slide, who have been involved with the recruitment, enrollment, and retention of these study participants in the study through the hard work from all of the community health workers, as well as Child and Family Empowerment Services, who offers and provides support groups for the women who identify as Native Hawaiian and Pacific Islander in our study. And so Embrace is a community-based participatory research study which asks the following question of: will integrating culturally relevant modules and support services for women into the Wellness Bus improve outcomes related to maternal mortality and morbidity and diabetes and gestational diabetes among women who are Native Hawaiian and Pacific Islander between the ages of 18 to 44 years old living along Utah's Wasatch Front? And Embrace includes a total of 155 women between the ages of 18 to 44 years old. And of these women, 102 identify as being Native Hawaiian and Pacific Islander, while the remaining 53 women identify as being from other racial and ethnic minority backgrounds, including Black and African American women, Hispanic and Latino women, and refugee and New American women. And this study design aimed to have 160 women, of which 102 are Native Hawaiian and Pacific Islander, and the remaining 58 are from other racial and ethnic minority backgrounds that I had previously mentioned. And so Embrace has 3 different groups within the study. And these include the Native Hawaiian and Pacific Islander Ocean Group, which is the intervention group who receives a curriculum that is grounded in Native Hawaiian and Pacific Islander culture and the heritage arts. It also includes the Native Hawaiian and Pacific Islander Mountain Group, or the control group, who receives a general curriculum that is tailored for women of color. And during the enrollment process, Native Hawaiian and Pacific Islander women are randomized either into the mountain group or the ocean group, and that is what decides which curriculum they will be receiving. Embrace also has a third group, which includes all other women in the study who are not Native Hawaiian and Pacific Islander, and they are the mountain group and are the comparison group to both of those groups. So one thing that is important to note is that both the Native Hawaiian and Pacific Islander mountain group and the non-Native Hawaiian and Pacific Islander mountain group will receive the same curriculum throughout the program. In addition, you can see on the slide that the study is broken up into two different time periods where we have two cohorts. So our first cohort of 82 women began in April 2021 and is expected to finish their 9-month screenings by the end of the month. And cohort 2 includes 73 women and began in August 2021 and is expected to complete sometime around July to August 2022. And so in order to understand the context and reasoning behind Embrace, we need to first understand that Embrace was created using a health equity mindset. So this means that it is intentional, strategic, and open-minded about partnerships. It also addresses health in context and profoundly recognizes and values lived experience. And it also fosters power building and sharing. And finally, it is able to operate with flexibility, adjust quickly, and advance in uncertainty. And some of these elements can be seen from what I've previously just shared through our partnerships and purpose. And moving along the presentation, we hope that you can see how it fits into all 5 of these strategies. And so there was a lot of collaboration for this project between the Office of Health Disparities, the Wellness Bus, and the community health workers. Community health workers are critical to the implementation of this study as they bridge the gap between community members and the study, as they themselves are members of the community and understand the components of the studies. And throughout this project, community health workers have been meeting with community members to collect data using REDCap, which we have trained them on extensively. And this has helped to not only assist with data collection, but has also expanded the capacity of community health workers, as traditionally they would not have gotten this type of experience. One thing that I'd like to share here is from one of our community health workers who said that she appreciated the study design because it felt more person-centered and focused, and having the community health workers do it and collect the data allowed it to be a much more authentic interaction. And now I'll hand it off to Deepani to talk about the data.
Thank you, Bon. So what I'd like to talk about here is how we approached data and data analysis with a health equity mindset, specifically making sure that we fully understood the health of Embrace participants in the context of their lives and socioeconomic needs, as well as recognizing and valuing the strengths and challenges of the participants' lived experiences. Without this approach, it's not possible to correctly interpret the data or to design programs that have true impact. Before designing the Embrace study, there were some important indicators that really stood out and that we focused on. These 2 tables show health disparities in maternal mortality and morbidity and related indicators. We see significant health disparities in these indicators, and poor health outcomes were significantly higher among Pacific Islander women compared to Utah women overall. If we take a look at severe maternal morbidity, which is defined as unexpected outcomes of labor and delivery that result in significant consequences to a woman's health, we see that the rate of severe maternal morbidity among Pacific Islander women was 204 severe maternal morbidity cases per 10,000 pregnancy-associated hospitalizations, compared to Utah women overall, who had 115 such cases. The occurrence of severe maternal morbidity is itself associated with other pregnancy-related risk measures, such as obesity in pregnancy and preterm birth. In these measures, Pacific Islander women also face significantly higher health disparities. More information about maternal mortality and morbidity health disparities in Utah can be found on the Utah Department of Health website, and there's a link that just was put up in the chat. Racial and ethnic minority communities in Utah also experience health disparities and diabetes prevalence and related indicators, which impact well-being, longevity, and economic and social mobility. As with the maternal mortality and morbidity indicators, diabetes-related health indicators show some of the highest health disparities among Pacific Islander women. For example, diabetes prevalence among Native Hawaiian Pacific Islander women was significantly higher than Utah women overall, and more than double the rate at 17% versus 7%. In addition, Pacific Islander women had the highest gestational diabetes rate in Utah at 12% compared to 6% for Utah women overall. Again, more information about health disparities related to diabetes is available on the Office of Health Disparities website, and also a link was just put up in the chat as well. So as we follow the health equity mindset, it's important to put these data about adverse health outcomes into context. So first off, social determinants of health really matter when it comes to health disparities. One metric we were able to look at is the Utah Health Improvement Index, which is a composite measure of social determinants of health. Very high and high health improvement index areas are geographic regions where residents experience lower educational attainment, lower median family incomes, higher rates of unemployment, and higher poverty rates. Many of Utah's racial and ethnic minority populations, including Pacific Islander communities, live in urban areas that are rated either high or very high on the Utah Health Improvement Index. In addition, Pacific Islander communities, along with other racial and ethnic minority communities, have less access to healthcare and health insurance compared to Utah overall. 23% of Pacific Islander individuals have no health insurance, while 13% of Utahns overall have no health insurance. And 26% of Pacific Islander adults say that cost is a barrier to healthcare, compared to 13% of Utah adults overall. So overlaid on top of the social and economic barriers that Pacific Islander women face daily is a cultural context unique to Pacific Islander communities. Pacific Islander societies are matriarchal, and women and matriarchs take on incredible roles and responsibilities. With that comes stress and anxiety, which can manifest in poor physical and mental health outcomes. However, women don't often have the time to take care of themselves, since in their collective community culture, they're used to putting others first instead of themselves. Also, the role of being a mother is important to Pacific Islander women, and having several children is very desirable and viewed as a blessing. Through this lens, we see that the connection to high birth rate in this community. So among Pacific Islanders, the birth rate is 18.2 births per 1,000 residents, compared to the birth rate of Utah overall, which is 10.6 births per 1,000 residents. Also within this context of the norm of large families, the practice of birth spacing may become less important. 42% of Pacific Islander women become pregnant within 18 months of their last birth, compared with 30% of Utah women overall. Multiple pregnancies shortly spaced really takes a toll on the body and puts Pacific Islander women at higher risk for adverse health outcomes. So as a Pacific Islander woman living in a Western society with its fast pace and perhaps less of a support network, trying to fulfill Pacific Islander roles, it can be really challenging. And the holistic health of Pacific Islander women is often overlooked. So here I'm going to discuss a little bit about the Embrace studies, the study and evaluation design, and present some preliminary data. So as Bon described, the study enrolled racial and ethnic minority women ages 18 to 44 living along the Wasatch Front, which comprises 4 counties extending north and south from the Salt Lake City metropolitan area. The main focus of the Embrace study was on the health outcomes of Native Hawaiian and Pacific Islander women who were randomized into an intervention group and a control group. But because other racial and ethnic minority women in Utah face health disparities, they are also included in the study as a comparison group. The intervention group of Pacific Islander women received a health curriculum grounded in Pacific Islander culture, while the Pacific Islander control group and comparison group received a curriculum that was more generalized to women of color. Also, the Embrace study was implemented in 2 cohorts, with time as the only difference between their enrollments, as opposed to a continuous rolling enrollment. So as part of the Embrace curriculum, all participants had their biometrics measured at baseline, 3 months, 6 months, and 9 months. They took mental health and self-care surveys and were also asked about behaviors related to physical activity, nutrition, and sleep. The outcome variables we looked at were indicators related to maternal mortality and morbidity, as well as indicators related to diabetes. These indicators included biometric measures such as BMI, waist circumference, blood pressure, A1C, which is a measure of blood glucose, and cholesterol, among others. We also looked at mental health and self-care indicators such as postnatal depression, anxiety, self-care behaviors, and resiliency. And finally, we also looked at behaviors related to physical activity, nutrition, and sleep. And the experimental variable in this study was a culturally appropriate health counseling and resilience building program applied over the course of 6 months, which was received by participants in the intervention group. So presented here are some preliminary data from biometric screenings done at baseline when participants first enrolled in the study. Just a quick side note to say that there is an error in the BMI data, which we are working on resolving still. So the data show that there were significant differences in the biometrics of the study participants as they were coming into the study. And the important finding here is that Native Hawaiian Pacific Islander women, compared to other racial and ethnic minority women, had significantly higher levels of obesity, hypertension, and diabetes. So the profiles that I showed you earlier corroborate the evidence that we were seeing within our study participants as well. And in our study, 10% of Native Hawaiian Pacific Islander women were dealing with diabetes at the time of enrollment, compared to none in the comparison group. Presented here are baseline measures for mental health and self-care for cohort 1. There were fairly high levels of depression among the Embrace women. Over a third of all women screened high for depression, and about 15% of women overall screened high for anxiety. Related to this, a third of women overall at baseline had low levels of self-care, meaning rarely or never engaging in self-care, and about 15% had low resiliency. As our data become more available, we'll be paying close attention to mental health, self-care, and resilience, and looking for any changes to these indicators, because knowing the larger context, good mental health and resilience is just so important. And finally, I wanted to take a moment here to spotlight one of the mental health assessment tools used in the Embrace study, in particular, the mindfulness self-care scale. This is a standardized tool that assesses self-care practices, looking at, for example, levels of mindfulness, supportive relationships, and maintaining life balance. Typically, such a tool is used in healthcare settings. An innovation of Embrace was the introduction of the mindfulness self-care scale into a research setting. This created the opportunity for the tool to be used with women who otherwise wouldn't have had an opportunity to access knowledge of mindfulness and self-care information from a healthcare provider. So the use of this tool also helped reinforce the importance of self-care during the pandemic, which was a win in itself. And now I'll hand it back over to Bon to talk about the fundamental importance of integrating head and heart when doing this kind of work.
Yeah, thank you, Deepani. So as Deepani shared, we understand the cultural, historical, and community connection, and that's how we came about the data collection portion of Embrace. And so the study, the design of the study is rooted in compassion and empathy, and also in the way that we go about the data collection and the research study itself, as it's focused on embracing women where they are. One way all of this manifests is through an activity that all participants go through, which is the individual health coaching session, where we have 2 registered dietitians who collect all of their information in that session through conversation rather than checking off boxes. And this is a way that it makes it feel more organic and authentic rather than feeling like it's a sterile conversation. And this all culminates into how cultural components lead to understanding the needs of the community. And this is crucial for Embrace, as it helped us to design the group health coaching sessions and the individual health coaching sessions through compassion and empathy, specifically as the focus of both of these is on self-care and resilience. And self-care and resilience among these communities is often seen as a selfish act, where taking time for yourself is very individualistic and doesn't help the larger community. This is because in popular culture and society, self-care is viewed in a manner that is not accessible or achievable. So for example, like taking an hour or 2 to get like your nails done or go get your hair done. Whereas with Embrace, we showed the participants how to reframe self-care as being beneficial for a collective society and help women to achieve their roles in the larger view of their community. If they take a few minutes to do a meditation, repeat their affirmations, move their bodies, or nourish their bodies. And so Embrace really looks at culture as a mediator for health outcomes, and the group health coaching session, which is the culturally grounded curriculum that the intervention group participates in, gives the participants of the study the space and the time to ask specific questions about their cultural identity and how that connects back to their own health. It also shows that their own ancestral practices were rooted in this, and that the traditional practices were done in a way that took care of the health and well-being of themselves and as a community. And in order to measure these sessions, we do have a cultural humility scale that participants complete as a survey. And these formats and the sessions allow for more in-depth conversation regarding their health and well-being while being culturally grounded. And all of this is being done through a health equity mindset, as it allows us to view and think about health and well-being through multiple lenses. And so here we'd like to share very briefly the group health coaching sessions. You can see the titles of it on the slide. So this is where culture is a mediator for the health outcomes, and where the group health coaching sessions really allow us to give the space and the time for the participants to be able to share about their cultures and how to connect it back to health. The group health coaching sessions are really where the qualitative data thrives, as these sessions are rich with women sharing their own lived experiences, connecting with each other. And throughout all of this, we have the community facilitator leading and guiding the conversation. And the community facilitator is one of the community health workers from the Utah Pacific Islander Health Coalition. So she is really connected with all of the women. And so as we end our presentation, I'd like to leave you with these final thoughts. So starting with a health equity mindset and using that mindset throughout an intervention or a program is crucial to maintain that understanding, especially when it comes to data disaggregation and how to design programs to close the gaps between health disparities. And finally, remembering that at the center of all this, we need to center the communities that we're working with, and fostering those community connections is vital and foundational for a program and for data collection. We'd like to end on this one last reminder that health equity means giving special attention to the needs of those communities who face the greatest health disparities. And now we can go into questions. I'd also just like to say a huge thank you to everyone who's part of this study. Brittany Okada is also listed on the slide, and she is really foundation of Embrace in creating it. And unfortunately, she wasn't able to be here today, but her contact information is here if you'd like to reach out.
Thank you so much. That was wonderful. This has been, between the two presentations, all of the additional like richness and culture and narrative and emphasis on that has been really refreshing to see, especially, you know, in culture of data. I think a lot of people are used to really heavy analytical studies, and so it's nice to see kind of equal weight being distributed. So thank you both. I'm going to give people a moment to enter questions in the chat or come off mute if you'd like. I had one question to start. How was the curriculum itself developed? Like, who was involved in that creation? Yeah, just what was that process like?
Yeah, that is such a good question. Would you also like me to stop sharing my screen?
Sure, yeah.
Okay.
If it's just as easy to maybe put your emails in the chat, so that way people can get in touch if they would like to.
Okay, cool. I will add that in. So for the curriculums, this was really truly a group effort. It really began with our group at the Office of Health Disparities, with Brittany Okada really bringing together everyone from the wellness bus and the registered dietitians. We also, because this study is really big, we weren't able to add in like everyone who was part of it. So we also have our partners with the University of Utah OBGYN division, and we have Dr. Michelle DeBink and her research assistant Ciale, who is Native Hawaiian and Pacific Islander herself. And we all came together and created these curriculums together. So we have really three different curriculums. We have the intervention curriculum for the individual health coaching sessions, and that is that includes like the nutrition and physical activity, as well as added self-care at the end. And that was really created with the registered dietitians putting their input and us just adding in those cultural components, with feedback from Ciale about how to make it really culturally grounded. And then for the control group or the mountain group, that was a more generalized curriculum that was tailored for just our communities of color that kind of have a shared like understanding and just really tailoring it and making it more general for them. So those are the two individual health coaching session curriculums. And then we have our group health coaching session curriculum, which is only for the women who are Native Hawaiian and Pacific Islander in the intervention group. And that curriculum, I feel like was a lot of like soul work and just so much learning. It was incredibly beautiful to be part of and to hear it. And for that, we had our cultural advisor, Nia, who is Tongan, and she really gave us we would just kind of like sit in like hour-long conversations, and she would just tell us stories, and we would kind of all together piece it together and go through many iterations to be able to develop the one that is about tapa making and weaving mats. And then our second group health coaching session was just all about mana and how to reclaim that for your health and well-being. And we had that feedback from Nia and weaving it together, and then also running it through the community facilitator, Tima, to make sure that she loved it. Because if she didn't, then we would go back and like edit it. But yeah.
Wonderful. Thank you so much. I love the description of it being soul work, because I think that probably connects a lot of us with this work as well. So thank you. One question came through about the funding mechanism for your work. So were there any Title V MCH block grant fund, or was there any funding from that block grant that contributed, or how was your work funded?
Yeah, so our funding comes from the SPI grant from the Office of Minority Health. And I believe that stands for the State Partnership Initiative grant. And so that grant was really just about focusing on health like specific health disparities. And I apologize, I feel like Brittany would be the best person to answer this. So I'll just give a very general, like what I know about it. But that grant was specifically focusing on 2 different health disparities and how we can like bridge that gap between them. But if you would like to email any of us, we'll put our emails in the chat and then we can give you a better answer.
Perfect. Thank you so much. And did you work with your state maternal and child health program for this work?
Yeah, so we did partner with, for the mental health and self-care and resiliency portion, we have the maternal mental health program, and we worked with a specialist in that program at the Utah Department of Health to really give us guidance on how to do the self-care portions and provide mental health resources to the women who are experiencing high anxiety, high depression, who may share that they have suicidal ideation and that sort of thing.
Wonderful. Thank you so much. I don't see any additional questions in the chat. I'll open it up for both groups if people have questions for either set of presenters that they want to ask before we jump off today. I'll make some of my closing remarks, but please feel free to enter any more questions and I'll read them off if I see them come through. But thank you all for attending this session. I know I was learning a lot, and this is my heart and soul work as well. I work with maternal and child health data, and so this was really refreshing and wonderful to hear from all of you. Slides and any additional handouts are available on the conference website, so I would encourage you to take a look at those if you'd like to review any of the information that you heard today. Everyone will receive a conference evaluation in their email. And as someone who is part of the conference planning committee, I would encourage you to fill that out. That information does help us in making decisions about what was relevant, what you enjoyed, and make the Culture of Data conference really the best it can be for next year as well. And there is one last live session of the conference, and one more walk and learn, I believe they're called, session this afternoon. So I would encourage you again to stay on and enjoy the rest of the conference. And if you enjoyed this, please go look for or keep an eye out for the Public Health in the Rockies conference, which is another great event that CPHA puts on. So I think that's all I have for everyone today. Thank you so much, especially to our presenters. You all did a really wonderful job, and I'm looking forward to continuing to follow your work in the future. Thank you, everyone, and have a wonderful rest of the conference.